So this is Steve. This is my Cardioversion OSCE wireless, and I'm Isaac. We've come in today and seen Steve. He's called us for his chest pain. When we arrived, he looked quite pale and clammy and appeared to be short of breath. He said that about 5 years ago he had this MI, and the symptoms he's feeling now are different. That's his medical history, and he's currently on Cladribine and aspirin. But because Steve is pale and clammy, short of breath, and has this chest pain, we're going to get him onto the floor. Just going to quickly assess the GCS. So when I arrived, he opened his eyes spontaneously, so it's a 4. When I asked him to sort of grab my hands and squeeze my hands, he was sort of unable to do that, so we'll give that a 5. And about a 3 for voice, because when I started talking to him, he started deteriorating a little bit. So because of that, we'll chuck him onto the floor. So we've got Steve on the ground now, so now I'm going to do a full set of vitals. Okay. First of all, because of his presenting complaint, we're going to have a feel for his pulse. So I'm going to feel his pulse is quite fast and rapid. So we'll put a 3 lead on and have a look at the heart first. So we'll put the monitor on. Allow it to turn itself on. Okay, put up sort of lead that we can look at. P3AF. It's looking like quite a wide complex tachycardia, but I'll print it out just to clarify that. Which it is. So from before, Steve's GCS is low.
Check patient.
Steve has a sort of low GCS now. His GCS is sitting around 4, but he's still able to communicate slightly, so we're still thinking consciously. Looking at that, it is confirmed wide complex tachycardia. But what I want to do is I just want to rule out my differentials, so I don't want to have SVT with aberrancy. And doing my other set of vitals, so blood pressure coming back at sort of 90/50, his heart rate is 130 at the moment, and his temperature is 37, so I can rule out any sort of things like infection, and his BGL comes back as 7, so I'm ruling out hyperkalemia or infection as well. So I'm thinking more along the lines of the conscious VT. So we're going to call call control for an R50. So AET1 to control.
Go ahead, AET1.
AET1 requesting R50 for a status 1 conscious VT.
Copy, standby.
Cool.
Comms to AET1.
AET1.
Yes, negative on that R50. R50 is currently attending a cardiac arrest about 35 minutes away from your location.
Okay. That's right. So, in that case, we've got the R50 coming en route. But what I'm going to do now is, because I want to adequately sedate my patient so that I can cardiovert him, I'm going to call clinical desk. So, I got permission from clinical desk now to administer ketamine, which is my out-of-scope practice drug for sedation.
Check patient.
So what I'm going to do is it's 0.5 milligrams per kg. So my patient is 80 kg, so we're going to use 200 milligrams. So we'll push that through like so and flush it. Okay, so now it's now been done. So now my patient is adequately sedated. Hello, can you hear me? Okay, so still got no response from Steve. So what we're going to do is we're going to go through my checklist. Okay, so I'm going to get my offsider here to run it through with me. Hold it. So, we have adequately sedated my patient. Hello, can you hear me? Alright, so we got no response from Steve, okay? So I've got my offsider here.
Yep.
So he's going to read the Cardioversion checklist out to me.
Okay.
Make sure I've covered everything before he shot.
Okay, cool. So place pads in either apex or sternum,
Cool, so we've done that.
or anterior posterior position, which is fine. Ensure the defibrillator is in manual mode.
Correct, it is.
Select a lead with a visible R wave.
As shown here. Yep.
And ensure that there's minimum artifact.
There is absolutely no artifact with this.
Okay. Select synchronized mode.
We've selected synchronized mode already, yep.
Okay. Confirm there's a detection of symbol above every QRS complex.
Yep, and I'll just clarify that by printing off. So it's obviously done.
Okay.
So printing off now, having a look, making sure there's a detection symbol above every R wave. Cool, so looking at that, there definitely is, I can confirm.
Yep.
Brilliant. And you can confirm as well.
Yep.
Sweet.
So the next thing is ensure that your patient has received adequate sedation.
Yep, so we've ensured that he's got adequate sedation given the ketamine.
Hello.
Got a response. Hello, can you hear me? Alright, still no response to pain stimulator.
Okay.
Yep.
So select the joules, charge the defibrillator, and confirm everyone is clear.
So selected 360 joules, max joules.
Yep.
Press charge on the defibrillator. Alright, everyone's standing clear, okay. Gonna hold down the shock button. Shocking. Shock. Enabled and delivered. Okay? Brilliant.
So next thing is determine the rhythm and the level of cardiovascular compromise.
Yep.
And then we are ensuring, so if we're administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
Brilliant. Pause it.
Just say still beating.
Yep. So, after that, we're looking at our monitor, my patient's still in VT. However, I'm going to just confirm that again by printing off another lead.
So say
And then we will carry on through the checklist once again.
Okay, so if it says if administering a second cardioversion, just confirm the defibrillation is still in synchronized mode.
Yep, so we're definitely still in synchronized mode. There's still a pacing spike above every R wave.
Yep, I'm happy with that.
Brilliant. I'm just going to confirm that my patient is still unconscious. Hello, can you hear me? Alright, still no response, okay?
Okay.
So,
Select the joules, charge
Yep.
the defibrillator, and
so
confirm.
select
everyone's
max
clear.
joules and we're going to start charging again, okay? Charging the monitor up. Alright, everyone's standing clear, making sure that there is clear, Sid, watch out. Alright, shocking, holding down the shock. Cool. And then we'll reprint another rhythm off and to see if it has worked. So looking at the monitor at the moment, it appears my patient is now in normal sinus rhythm, which I can clarify with looking at on my rhythm strip here. Yep, brilliant. And we'll just reassess vitals, maintain patient being warm, so I can use a blanket, put the blanket over my patient, make sure that's nice and passively warm. Give them oxygen if we need to. We can give fluids as well. Through our IV cannula we've already done.
Yep.
Take another blood pressure, heart rate, respirate, another BGL temperature, full set of vitals, another 12 lead. And we'll transport and also R40 en route.
Yep.
And we'll let our R50 know what we've done.
Yep.
Hi, I'm Isaac. This is my RSI assistant, ILS OSCE. Today we have been dispatched to a 24-year-old male who has fallen from a height of 2 stories. Upon arrival, we are greeted by the construction staff, and they've told me that he's fallen and he's lying on his back currently, so he's lying supine. When I'm approaching my patient, I'm looking at him. He has appears to have a clear airway, appears to be breathing quite rapidly, and appears to be quite pale. We then go ahead to assess his GCS. his GCS. So he's standing, he's lying there, and he is posturing and cerebral, so posturing outwards, which gives me a motor score of 2. He is opening his eyes spontaneously, so I've got a eyes score of 4, and he is moaning and groaning, which gives me a verbal score of 2. Therefore my GCS comes back as a GCS of 8, and for that matter I will be calling for a RSI endorse R50. So 81 to control.
Go ahead, 81.
81 requesting RSI endorse R50 for status 1 TBI.
Copy that, 81. RSI en route.
Would you like me to prepare the checklist?
Copy that. Prepare checklist. Thank you.
Will do. So we've come to assess my patient. I've got my offsider gathering a history of my patient for me. While he's doing that, I'm going to look and make sure the airway is patent, and it is. I've got a non-rebreather on, giving my patient oxygen. I'm looking at his breathing. It appears to be rapid and irregular. Just sort of looking down, thinking about circulation, feeling for a pulse. It's quite, it's a good pulse, but it's weak and slow. And then we go on, and I've taken a full set of observations. He's got a temperature of 36.5. He's got a saturating at 92%. His blood pressure is 150 or 90. His heart rate is 55. His BGL is 7.2, and his rest rate is 24. So after talking to my offsider again, he's told me that my patient doesn't have any obvious medical history. We're unaware of any allergies to any medications, but there's no sort of obvious underlying factors to why he might have fallen from the construction site. As per before, my ICP en route has asked me to prepare the RSI checklist, or preparation for his RSI. So, pull up my CPGs, go to the RSI checklist page, the preparation for RSI, and we'll go along with this, just to make sure I haven't missed anything out. So we've attached the nasal prongs without oxygen. I've pre-oxygenated my patient with a reservoir mask. I've attached an ECG and its valve lead. I've got my blood pressure cuff on. Patient saturating. Got my SpO2 on. I prepared my capnography. As you can see, got my monitor in a nice position so that my ICP can see it from where he is going to be. I've gained IV access in 2 sites. Prepared my running line with my sodium chloride. I've also positioned my patient in a nice optimal position for his airway. However, because of his spinal injury, I've put a collarbone on. I've also supported the head so there's no movement. So the neutral alignment is the best position for my patient instead of having him in the sniffing position. I've got my ET tube holder underneath my patient, ready to go. Check my suction, but as I did before I did my critical checks, it worked. So I'm here, and off. Bring this all working. I've got my manual ventilation bag with my PEEP on, capnography, still ready. I've obtained a set of vitals already gone through and done that. What I'll do is I'll update my ICP and tell him that we've got everything prepared for him and everything. Also got a big open area here for intubation roll to be set up. So, post intubation, if the RSI has failed, we can do a second attempt. In the second attempt, we can get a bougie, and the bougie will go down first, which will then go through the cords after they're sighted, and then you place or pass the ET tube over the bougie. The RSI assistant can help with this by holding the bougie and helping to slide the ET tube over the bougie. After this, if there's no maintaining of 5 mils of water capnography, then it's classified as a second failed attempt. In this case, we will take the EC tube out, put an OPA in, and continually ventilate with a bag mask and PEEP set to 5. If those who have failed, though, we do have one other option, which is to do a cricothyroidectomy, cut through the cricothyroid membrane and pass a tube through there instead. During the procedure, a paramedic or an RSI assistant can help with administering medications and drugs, and also helping with airway and any tasks that the RSI ICP requires.